webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host and moderator for today's webinar. Today, Dr. Cameron Carter will present a webinar entitled Brain Networks in Schizophrenia and Bipolar Disorder, Targets for Novel Therapies. The Brain and Behavior Research Foundation is dedicated to funding research around the world to identify the causes, improve treatments, and ultimately develop cures and methods of prevention for mental illness. The Foundation has awarded over $300 million in research grants over the past more than 25 years. I'm delighted to introduce Dr. Cameron Carter. Dr. Carter is Professor of Psychiatry and Psychology and Director of the Center for Neuroscience and the Imaging Center at the University of California, Davis. Dr. Carter's clinical interest is in the early diagnosis and treatment of neurodevelopmental disorders. His research focuses on understanding the neural basis of healthy cognition and the pathophysiology of disturbances in higher cognition and emotion in patients with brain and behavior disorders such as schizophrenia, bipolar disorder, and autism. He is working to provide new understandings of the nature and causes of these disorders, and as a result, contribute to the development of therapies that can improve people's chances of recovering their functioning and improve their quality of life. His work reflects the latest in neuroimaging and electrophysiology technology. Dr. Carter is a 3-time NARSAD grantee in 1994, 97, and 2003. And he's the recipient of the Foundation's Clearman Prize for Exceptional Clinical Research by a Young Investigator in 2001. He is also a distinguished member of the Foundation Scientific Council. The Council selects the most promising ideas to fund with NARSAD grants each year. This will be an interactive event. We'll start with Dr. Carter's presentation, followed by a question and answer period. To submit your questions, please use the Questions tab of the webinar control panel. You can submit your questions throughout the presentation. As your moderator, I will present your questions to Dr. Carter, and we will address as many as possible. And now, I'm pleased to present Dr. Cameron Carter. Cam, the floor is yours.
Good morning, everyone. It's a pleasure and honor to be here giving this talk to you today. I am going to be talking about how advances in basic cognitive neuroscience and in the use of imaging and electrophysiology methods from cognitive neuroscience in studies of patients with serious mental illness such as schizophrenia and bipolar disorder are giving us a new and very robust understanding of the functional circuitry that underlies the symptoms and signs and deficits that patients have, and in doing so opens up new possibilities for interventions. We all know that schizophrenia and bipolar disorder are very common illnesses. Each of them affects roughly 1% of the population worldwide. The risk of these illnesses is determined by genes, a fairly large number of them, as well as environmental risk factors, some of which we have yet to understand. These illnesses affect many aspects of mental life and behavior, from perception and emotion to cognition and memory. And I'll be talking in more detail about those aspects of the illness during this talk. And the best outcomes to date are obtained by early intervention and the use of evidence-based treatments as proximal as possible to the onset of the disorder. I'm going to be talking a lot about cognitive deficits and negative symptoms today. These are treatment refractory aspects of the illness. Unlike the positive symptoms, things like hallucinations, delusions, mania, cognitive deficits and negative symptoms don't respond to our antipsychotic treatments. And this is a big challenge that we must face as a field. I focused a lot in my research on cognitive deficits in schizophrenia, and I'll describe these soon in a little bit more detail. The important thing to recognize about the cognitive deficits that are seen particularly in schizophrenia are that they're present at the very onset of the illness. In fact, even before people begin to have psychotic symptoms such as hallucinations and delusions, they experience changes in their cognitive functioning, difficulty concentrating, sometimes difficulty remembering, or difficulty organizing their behavior. So even during the prodromal state, these symptoms appear and they persist throughout the lifespan once the illness has begun. It's been known now for 15, perhaps almost 20 years, that cognitive deficits are very strong predictors of disability in schizophrenia, even more so actually than the positive symptoms. I think those of us who are clinicians know that there are patients who will have some residual hallucinations or even delusions, but they learn to cope and manage with those symptoms, to not respond to them, and they're able to function. It's people with impaired cognition and the associated disorganization that have most difficulty taking advantage of the opportunities for recovery of function that are available these days. I mentioned already that our currently available treatments have little impact on cognitive disability in schizophrenia. That's true for negative symptoms as well. And that's a big reason why we need to try to understand what the root causes of these symptoms are so that we can intervene. Also, one reason to focus on this aspect of the illness is that we do have this remarkable basic science now as to the neural basis of cognition and emotion in the human brain. And we have tools that can allow us to probe these aspects of our mental life and the underlying neural circuitry. And it's a kind of low-hanging fruit for us to really dig deeply into the brains of people with these illnesses and understand the underlying mechanisms. The best way for us to treat problems that our patients have is to understand their causes and be able to address them. I'm going to talk quite a lot during this presentation about functional MRI, so I thought I would explain to you a little bit about it. Functional MRI takes advantage of MRI technology that you all may have experienced if you had a knee problem or a back problem or a neck problem. The difference with functional MRI is that we tune the scanner to be sensitive to a signal to the level of oxygenated hemoglobin in the brain. And this takes advantage of a quirk of the brain, which is that unlike other parts of the body, when the tissue works harder, oxygen gets consumed, and the oxygenation of the tissues and the blood in the capillaries goes down. In the brain, because our brain is so dependent on aerobic metabolism, which depends on oxygen, we have a special reflex that allows working tissues to actually increase their oxygenation. So when we have a scanner that at a very high resolution, down to about 3 millimeters by 3 millimeters by 3 millimeters, allows us to measure the level of oxygenation in the brain, we can then have people do cognitive tasks or emotional tasks, and we can essentially acquire a three-dimensional slow-motion movie of activity across their brain. So we can see which areas are active, and we can see which areas are working together as people process information. It's a very powerful tool. It's relatively new. It's been around for less than 20 years, used in clinical disorders for quite a bit less than that. But we now have a robust body of data that provides us with information about the nature of the neural circuitry that's affected by disorders such as schizophrenia and bipolar disorder. And this puts us in an interesting and I think strong position to begin to see functional brain circuits as targets for treatment and to begin to try to intervene. So just a few, there's different ways of doing fMRI. You've probably heard about resting state fMRI, which is also a very useful and powerful tool. I'm going to talk about that's where people lie in the scanner with their eyes open or closed, and we look at which areas of the brain are kind of talking to one another, are coactive while the brain is at rest or at least in an uncontrolled mental state. Task fMRI actually gives people something to do in the scanner. This allows us to make a number of important inferences regarding the brain-behavior relationship. First, it allows us to identify functional neural networks that are linked to specific cognitive and affective processes. It allows us to identify which of these processes are impaired and which are intact. I think this is something that cognitive neuroscience can tell us that's very important. People often assume that people with schizophrenia or bipolar disorder have some general global kinds of impairments, and that there are many, many, many things that they can't do. And while there may be some truth to that, at least when people are in a state of clinical relapse, It's also true that as we begin to systematically identify what people can do and what they can't, we see many things that are intact in people with schizophrenia. Won't really be, and bipolar disorder, it won't really be the focus of my talk today to talk about that, but I do think it's a very important thing to recognize that people with serious mental illness have many intact cognitive abilities, and understanding that allows us to take advantages of the strengths that people have, as well as to identify the areas of weakness where we need to do remediation. Task fMRI can also allow us to establish links between changes in neural circuitry, cognitive and emotion processing, and clinical symptoms and functioning. So building up an understanding from the neural level to the psychological level to the level of behavior, symptoms, and functioning. People have been studying cognition in schizophrenia and bipolar disorder for a long time using different methods. And in general, there are a wide range of disturbances that are recognized. These include disturbances in attention, and by attention I mean the ability to process information that's relevant to your goals at the moment and to ignore distractions. People have impairments in memory, and that includes short-term or working memory. That's the kind of memory that you need to keep a phone number in mind for a few seconds, or to keep information in mind to do arithmetic or algebra, or to follow a series of instructions, to follow a plan. People also have impairments in long-term memory, the ability to kind of store experiences so that they can be retrieved at a later time. There also are some disturbances in the ability to comprehend language and instructions in schizophrenia and bipolar disorder, as well as sometimes to produce language that is highly organized and coherent. And when language is disorganized in people, particularly with schizophrenia, we refer to that as thought disorder. Finally, there are disturbances in emotional processing, particularly what we call negative symptoms, where patients do not pursue activities that are likely to be experienced as being rewarding in the same way as they did before they became ill. These changes in motivation are often referred to as negative symptoms, and they're a notable aspect of schizophrenia in particular. I'll be talking today about a way of understanding these deficits that ties them to a disturbance in a set of processes that regulate all of these sort of independent little modular aspects of cognitive functioning. And those processes are referred to collectively by cognitive neuroscientists as cognitive control. And a sort of regular definition of cognitive control is those processes that need to be engaged when habitual responding won't do, and you have to use instead an idea or a representation of the goal that you have in order to guide your behavior and to overcome or override your habit. So you know, a great example of this is if you've ever traveled overseas, perhaps you've been to London and you've come out of the tube station and you're going across the street and you take a look, and if you're coming from the States, your first instinct is going to be to take a look to the left and step out onto that crosswalk. But if you do that in London, that will cause you a great deal of problem because traffic is coming in the other direction. And so you need to overcome that habitual response by holding in mind the fact that you know that you're in London and people are doing things in an opposite way in order to save your life in this situation. When we test cognitive control in healthy individuals or people with mental disorders, we typically use tasks like this, the Stroop task. When you see a word like this, you want to read it. In fact, you can't help reading it. The reading areas in your brain become active because reading is a very habitual overload response. But in the Stroop task, what you're asked to do is to ignore the word and to name its color. When you get a stimulus like this, you're reading the word green, but your job is to say red. There's competition between those two things, and it takes cognitive control to resolve that competition and to stop you making an error. If we were in a live audience talk now, I'd probably have you do this task, and at least a couple of people would probably, when they saw this word, say green, even though they meant to say red, because it takes a lot of cognitive control actually to perform this task, which looks simple but actually is somewhat difficult. When we do functional MRI studies of this task, we can give people a cue down here that tells them whether their job is to read the word, which would be red, green, or blue, or name its color, which would be red, and green. And when we give them that cue, when they're cued to do the difficult color version, activity in the prefrontal cortex, and particularly this area of the dorsolateral prefrontal cortex, ramps up over the several seconds before they have to respond to the word. And the degree to which people can activate this part of the brain correlates very well with how they subsequently perform in terms of the extra time it takes for them to get the right response out and to resolve that competition between the habitual response to read the word and the controlled response to name its color. And this result has been replicated many, many times and has linked this particular part of the brain, the dorsolateral prefrontal cortex, to a key role in a neural network that involves a bunch of other areas in the brain that are connected to it in representing the goal and using that to overcome a habitual response, which is a key element of cognitive control. Now, this role of the prefrontal cortex in control has been shown to extend beyond the kind of conflict tasks or attentional control tasks that I just showed you, the famous Stroop task, and to be something that is really quite general across many different domains of cognition. So just to review this very quickly, for those of you who may be interested, if you have people do a perceptual decision-making task where they have to decide whether a stimulus that's very faint is there or not, or if they have to make a judgment between two stimuli as to which is the brightest, and the stimuli are very close together so that the decision is hard, you recruit your dorsolateral prefrontal cortex. When you have to do a difficult working memory task where you have to keep in mind large numbers of items and also do things like reorder them or maintain their temporal order as they're appearing one by one on a computer screen, you recruit the dorsolateral prefrontal cortex. When you do a difficult memory task that requires you not just to learn items and to recall them, but actually to learn the context in which they were learned in. So just remembering a picture of a pencil doesn't really recruit the prefrontal cortex. But if you have to recruit if you have to remember a pencil plus the context in which you use the pencil, that will recruit the prefrontal cortex. And it's also been shown in the neuroscience of emotions and social cognition that under conditions in which you have to regulate emotions, either use context to sort of rethink them in order to manage your emotions or even do emotion suppression, then the prefrontal cortex is recruited. So this suggests in basic cognitive neuroscience that there's a domain general control-related role for this prefrontal cortical area. And that is a reason that I've been talking about this. And that is because when we do studies of people with schizophrenia, over the years, one of the more reliable findings when we do fMRI is that when we give patients a cue that says engage cognitive control, people with schizophrenia have trouble activating this part of the brain. And in fact, it's not just the activation that's difficult. Healthy control subjects recruit a distributed network during a task like this cognitive control task that people are doing in this experiment here. The degree to which they can recruit this network along with activating the dorsolateral prefrontal cortex predicts how well they can do in their cognitive control task. This is a study comparing a group of healthy young individuals to people with first episode psychosis. Actually, all these individuals had first episode schizophrenia. And what we showed was that not only did people with schizophrenia have trouble activating the dorsolateral prefrontal cortex, but they failed to recruit the task-appropriate network that you need in order to overcome a habitual response. And associated with this change both in activation and in functional connectivity, that's what we refer to as the ability to recruit a task-appropriate network, the degree to which people couldn't recruit that network was associated with worse task performance, more disorganized behavior, and decreased functioning. And this is also a result that we've seen in a number of subsequent studies, this association between prefrontal cortex, the ability to recruit a task-appropriate network, impaired cognition, behavioral disorganization, and functioning. And in fact, in a meta-analysis of fMRI studies using tasks that required cognitive control, a colleague of mine, Michael Minsenberg, showed a few years ago that there's this very reliable pattern of decreased recruitment of the dorsolateral prefrontal cortex. And interestingly, across studies, more inferior parts of the prefrontal cortex actually are overactive in patients, suggesting that they're compensating by drawing on other circuitry that isn't specifically involved in cognitive control, but which gives them a workaround in order to be able to cope with doing the task. To address whether this alteration in prefrontal cortex is really general to multiple different aspects of behavior, a colleague of mine, Dan Ragland, also here at UC Davis, did a similar kind of a meta-analysis where he took a large number of memory studies in schizophrenia, and he looked at people during the learning or encoding phase of the task, and he looked at people during the retrieval phase of the task. This is results from the encoding phase of the task, and as you can see, there are multiple areas here in red in the prefrontal cortex that are consistently recruited less in people with schizophrenia, particularly when they're learning more complex material involving context or relationships between items that they're learning, conditions that we know involve cognitive control during memory tests. And these data are from the learning part, but also during retrieval, the same pattern of results is shown. So this suggests that this finding goes beyond the kind of attention tasks that we were talking about into other aspects that of cognition that have been impaired in shown to be impaired in schizophrenia, such as memory. So what about emotion? Could these alterations in the prefrontal cortex and in cognitive control help us understand the changes in emotion that happen in schizophrenia? Well, it's worth thinking a little bit about what those changes are. And I'm introducing you here to an idea that there's a paradox about emotion in schizophrenia, and I refer to this as the Kring paradox because I want to credit my colleague Anne Kring at UC Berkeley, who first pointed out this paradox. And what is the paradox? The paradox is that we know that people with schizophrenia have reduced emotional expression and impaired motivated behavior. This is often seen emerging during the prodromal phase or not long after the first episode, and it's a big worry for families of individuals with schizophrenia to see this reduced interest in social activities, academic activities, work activities, and it's a big cause of disability in the illness. However, when you actually ask people with schizophrenia how much they enjoy things, you can do this in different ways. The original way was to give people questionnaires. Now you can do experience sampling. People used to give people pages and call them up during the day and ask them what they were doing and how much they were enjoying it. Nowadays you can use cell phones and smartphones and just set an alarm, have people do this kind of experience sampling. And what you find is that when people with schizophrenia are doing things that they like, they report that they like them just as much as anyone else does. It's very interesting. So it's not that people with schizophrenia do not obtain pleasure or reward from the things that they like. It's that somehow they don't pursue those things. So what could that be? Well, one possibility is that it could be that people with schizophrenia aren't using their memories and the information that they have about the things that make them feel good in order to actually organize and guide their behavior in the pursuit of rewards. So this suggests that alteration in the interaction between cognition and emotion. So not that emotions are broken, but that there's an interaction, there's a break in the interactions between cognition and emotion that underlie actually pursuing goals. So we did an fMRI experiment that was published a couple of years ago in the American Journal of Psychiatry, where we gave people a picture, and this is just one of our neutral stimuli of a person's face. There were also pleasant stimuli, and there were unpleasant stimuli. And these were emotional stimuli from a very, very well validated battery of emotional images. So we showed people the image, and then we told them that the image would go away for a while, and we wanted them to hang on to their experience, the emotions that were elicited by the image, because after several seconds we would have them do ratings. And then we had ratings as to how pleasant, how unpleasant, and how arousing the stimuli were. And we switched those ratings around all the time, so people couldn't prepare their response during the delay. They had to hang on to their emotional response. And here's what we saw. So these are our healthy control subjects. And what we see during all kinds of emotional experience, pleasant, unpleasant, and neutral, lots of activation in visual parts of the brain. So that's not surprising. They're looking at the stimuli, and they're processing perfectly normal. And then we also see activity in areas that represent emotions in the brain, so the basal ganglia, the orbital frontal cortex, the medial frontal cortex. And we see this varying across the kind of stimuli in the way that we would expect. And also areas that involve in attention, paying attention to the visual stimuli that they're looking at, so prefrontal areas. Now, what's very interesting is that when we look at this same comparison in patients, so this is while people are looking at the picture, we see very much the same pattern of activation. Lots of visual activation, activation in emotion areas, and activation in attention areas. And in fact, when we compare these two groups, there's absolutely no difference between the two. So in the moment, looking at these pictures, positive, negative, and neutral, the brains of the experience that the brain is having of emotions is not different between these individuals with schizophrenia and the healthy control subjects. So what happens when the stimulus goes away and people are hanging on to their emotional experience so that they can make their ratings in a few seconds? So I'll move you down to here to what we see happening during the delay in the healthy comparison subjects. And what we see is, well, not surprising, the visual cortex becomes inactive. So all that visual activity goes away, and that's because the stimulus is gone. People are still hanging on to the emotions. You can see this by the fact that there is activity in emotion processing areas in the brain, as well as in areas involved in attention. I don't have a figure of the activity in the patient's brain during the delay because there is none. Once the stimulus went away, their brains became empty and quiet and inactive. They were completely unable to hang on to that information and to maintain activity in both emotion processing areas and cognitive control areas. And this is the contrast of the healthy controls to the patient. So these are areas that are significantly more active in healthy controls to the patients. And again, what you see is areas that involved in emotion processing and areas that involved in attention, cognitive control, show reduced activity in the patients during the delay period. And the degree to which the dorsolateral prefrontal cortex, its cognitive control area, was inactive related quite strongly to the level of negative symptoms that people had. So what this suggests to us is that this prefrontal cognitive control change and the alterations in the functional circuitry that we can measure using fMRI related to this change can affect the processing of emotional information and be related to negative symptoms in the same way that it appears to be related to the ability to control task-irrelevant information and overcome conflict on an attention task. And in the context of an emotion task, taps into the anhedonia and the negative symptoms that patients have. So a summary here would be that basic emotion perception and responses are intact in people with schizophrenia, but delay-related activity is reduced, and this does suggest an alteration between prefrontal cognitive control systems and emotional processing systems, deficits and motivational deficits and negative symptoms in people with schizophrenia. And together with the other work relating the alterations in the function of this circuitry to tasks involving attention, working memory, suggests that this circuit, and particularly the hub in the prefrontal cortex, should be considered to be a target for intervention for both cognitive deficits and negative symptoms in the illness. Now, I'll just very quickly show some information that addresses what might be the underlying local circuit mechanisms related to changes that we can measure using BOLD. And then I'm going to talk a little bit about how we can actually use this information to develop some new treatments. So the question is, we can measure at the level of the BOLD signal, the BOLD signal being the blood oxygenation level dependent signal that we get from fMRI, the alterations in the sort of macro circuit, the distributed circuit across the cortex that's changed in schizophrenia under certain cognitive and emotion processing conditions. What underlies that? Well, one thing we know is that these signals are strongly correlated to population neural activity rather than the single neurons that fire in the brain, and particularly to large ensembles of neurons that are firing at a particular frequency, the so-called gamma band, 30 to 80 hertz, 30 to 80 times per second. So these are referred to as oscillations. And increasingly in neuroscience, we understand that neurons can fire in a variety of different frequency ranges, and that sometimes they'll fire at different times from each other, so that's asynchronous. So these are neurons that are firing asynchronously but sometimes the neurons become synchronized and they fire in sync and they fire a particular frequency, and it's increasingly understood that this is how the brain processes information, through the synchronization of networks, both locally in areas of the cortex, so those little blobs that we see with fMRI are due to neurons firing synchronously, and also the way that connectivity is established across the cortex is that the neurons also synchronize their firing long distance across the cortex to form distributed networks. And so we also know from postmortem studies in schizophrenia that if you zoom in on the cortex and look at the cells, that there is an intimate relationship between the pyramidal cells, which are the main kind of processing units in the cortex, and these neurons here, which are the inhibitory interneurons, such that when these neurons fire, they make these neurons fire, which then turn these neurons off. So there's a kind of closed loop. And we know that particularly these inhibitory neurons here, which are referred to as the path-albumin neurons, this is largely through the work of Ted Jones and David Lewis at the University of Pittsburgh, seem to release less gamma, and that's likely to disrupt this cycling, this oscillation that happens between the excitatory pyramidal cells and the interneurons, and that is likely to be reflected as a disruption in oscillations. This particular subclass of interneurons is particularly involved with two frequencies, theta and gamma. Theta is a lower frequency, and gamma is a higher frequency. We can measure these frequencies using EEG and while people are doing tasks, just like we do task fMRI. And what we reported a number of years ago and then replicated more recently in unmedicated first episode patients with schizophrenia is that there are substantial reductions in both the right and the left prefrontal cortex in this gamma activity in people with schizophrenia compared to healthy control. So just to talk a little bit about how this could all be fit together and form a substrate for moving forward and trying to address the question of what can we do about this.
Dr. Carter, I'm sorry to interrupt. Is there any way where you can pick up the handset? You're fading in and out of the volume.
How about I come a little bit closer like this, Nita?
Perfect. Thank you so much.
My apologies. So just to sort of summarize this link between what we believe is happening at the cellular level, which is a change in the excitation and inhibition balance in the cortex that may be due to an alteration in GABA release, to changes in oscillations that we can measure with the EEG, the changes in activity that we can measure using blood oxygen level dependent functional MRI during cognitive tasks, to changes in cognitive functioning, and to changes in symptoms. So how can we possibly use this information to try to improve things? Well, there are a couple of new directions. Traditionally, of course, we've used psychopharmacology to treat symptoms in patients, and there are many individuals and many pharmaceutical companies that are working on drugs, particularly related to GABA, to glutamate, and to nicotinic receptors, and to dopamine receptors. These are the receptors and the neurotransmitters that regulate that inhibition and excitation balance in the cortex. And so far, we haven't had any successes. I don't think that means that we won't have any successes, but I think progress has been relatively slow with regard to coming up with medication-based cognitive enhancers. But there are a couple of, and we should absolutely continue to persist in our efforts to develop those medications, and I know that there are a number of pharmaceutical companies and many individual labs that are working very hard on that problem. While we're waiting for that, we can begin to use what we know about this circuitry, the topography, that is, which of the parts of the brain that are involved, the physiology, how these areas synchronize with one another, and begin to try some other things that can improve cognition and negative symptoms. So the two things that I'll be talking about today are cognitive training and neurostimulation. There's a fairly long literature on cognitive training in schizophrenia, and there are a number of different approaches that people have begun to develop. I will show you results from a study that I completed in collaboration with Sofia Vinogradov from University of California in San Francisco. In first episode, schizophrenia patients, that replicates an earlier study that she had done in chronic patients using a particular kind of computer-based training. We had young people within 5 years of the onset of the illness. Actually, most of them were somewhat earlier in their illness than that. We gave them a laptop, and we randomized them to one of two groups. Either they played kind of old-fashioned computer games for an hour a day, 5 days a week, or they performed a particular kind of training developed by a company called Posicides. And this training involved having people make perceptual decisions early on, and then increase the attention demands, the working memory demands of that perceptual decision-making over a period of a minimum of 4 weeks. So here we have just some information about these individuals. I think the relevant things here is that they were young people who were relatively recently developed their illness, and yes, they completed on average between 30 and 40 hours of training. The exciting thing about this was that compared to the computer game condition, which is shown here, a number of areas of cognitive functioning significantly improved in the young people who underwent the computer training, the neuroplasticity training, and this is reflected in the global cognition score, which is kind of the average of all of these other things. What's also very interesting is Dr. Vinogradov, in a subset of individuals, has looked at gamma oscillations using MEG. So I showed you the EEG method of doing this. She uses something called magnetoencephalopathy, which records a different kind of signal but allows you to do the same kinds of analyses. And what she showed in that study was that people who improved their prefrontal gamma activity also showed the biggest gains in their on a measure of executive functioning related to the training. Suggesting that this training works, the neural networks, helps them to establish their connection, the connections that they need in order to maintain the oscillations within the time frequency domain that's needed for optimal processing, and also to synchronize those the elements of that network into a working distributed network. So that's cognitive training. There are discussions now about conducting a large multi-site study of cognitive training in a range of different kinds of patients, trying to figure out what kind of training is the best for what kind of person, as well as how to leverage the gains in cognitive functioning that are obtained during training into improvements in social and school and occupational functioning. So I think we're going to see a lot of work in this area, and it's very much directly driven by our understanding of the cognitive deficits and the neural mechanisms that are underlying the impairments that we see in people with schizophrenia and bipolar disorder. So I'll move on to just one other kind of intervention that takes advantage of our knowledge of the functional circuitry that underlies cognitive and emotion processing deficits in schizophrenia. This is a method called transcranial direct current stimulation. It's an area that's receiving a lot of interest in neuroscience research right now. Basically, it's very simple. It involves using a device that delivers a very tiny amount of electrical current to the scalp, just 2 milliamps, 1 to 2 milliamps is typically used. So you've basically got a device that's being powered by an 8-volt battery. And this is applied in a systematic way, targeting a particular element in the anatomy. So here, this is the anodal electrode. So this feeds electrodes to the scalp, and those electrons, I should say, are actually transmitted through the scalp and into the neural tissue in very low doses. It is located over the left dorsolateral prefrontal cortex. The way we think this works, and this is the cathode electrode, so it's basically a closed circuit. And it's necessary in order to get cognitive gains. It appears from the basic science research that you have to have the brain working while you provide this input. So this is really a way of kind of enhancing the effects of cognitive training. The way we think it works is that Electrical current changes calcium conductances in axons, and this leads to changes, particularly in glutamatergic neurons, and increased expression of AMPA receptors, which are very important for what's called long-term potentiation. That's the positive connections between neurons that are working together in a network. It's the basis of a lot of learning and memory, and is enhanced, we believe, through TDCS. This is a study that has been conducted by Brooke Roberts, who is a postdoc working with me at UC Davis, and Sharon Ranganath, a cognitive neuroscientist who collaborates with me as well. And I'll just describe this data as a sort of hopeful starting point, I think, to a program of research focusing on combining this method with cognitive training. So essentially, people are doing a working memory task. They're getting 2 milliamps of stimulation for about 20 minutes, and then we're testing them afterwards. And we're testing them on a task where if you have good cognitive control, you'll do badly on one kind of trial and well on another kind of trial. And if you have bad cognitive control, you'll flip. So again, this condition here is under conditions of good cognitive control. Cognitive control will make you make more errors. This condition here, under conditions of good cognitive control will help you make less errors. So here's what people are doing before the sham. They're making roughly equal numbers of errors in these two conditions of the task. And then right after TTCS working memory training, what you see is an increase in the AY errors and a decrease in the BX errors, a very nice statistically significant crossover effect. That certainly serves the basis for us to believe that this is a very promising method to take into people with schizophrenia. We're just doing pilot studies in them right now. So just to conclude and then open things up for questions, I hope that from my presentation it's clear that we've made a tremendous amount of progress over the last 20 years in understanding impaired cognitive and emotional processing in schizophrenia and bipolar disorder. I didn't show you bipolar disorder data today, but I do want to communicate to you that we've been looking in our first episode psychosis patients with these same imaging tools, and we see that our bipolar patients show in general very similar deficits, perhaps a little less severe than those that we see in people with a schizophrenia diagnosis, but many of the things that I've described to you today certainly apply to that population as well. And that our ability to study these mechanisms in patients is now allowing us to think at a larger scale, at a neural systems level, about how we can intervene, taking advantage of the brain's natural plasticity using methods like cognitive training, and enhancing that, if you will, or bootstrapping it by directly manipulating the neural circuitry using very benign methods of neurostimulation in combination with cognitive training. So that's the end of my presentation, and I'm going to turn things over to Dr. Borenstein, and he can moderate the questions.
Yes, great. Thank you so much, Dr. Carter, for an outstanding presentation on really very exciting work that you and colleagues are involved in. A first question related to the issue of cognitive training is for people who are who have a diagnosis of schizophrenia, what should they do? How do they go? How does somebody go about determining whether or not they benefit from this training and receiving this kind of training?
Sure. Well, I think the best way at this point is to participate in a clinical trial, because this is really still an investigational treatment. I also would sort of qualify that by saying that there's cognitive rehabilitation, which is, I think, part of practice in a number of health systems, and it involves an element of cognitive training, which isn't as sort of high-tech and neuroscience-based as what I described to you today, but is likely to be helpful and is embedded in other kinds of rehabilitation type interventions, including groups and problem-solving strategies, and also vocational and educational support. So So that more general kind of rehabilitation is really available in a number of community settings. So the first thing I would do would be to encourage people to ask about it, to see if as part of rehab services there's some kind of cognitive rehabilitation that's available. Then when you come down to this more time-intensive, technology-based training, I think probably at this point the best bet is to participate in a clinical trial. There are on the web, there are many tools that are out there that aren't evidence-based, and of course, mental health consumers will be well aware of that. That there's a lot out there that's not evidence-based, and at that point, people need to weigh the pros and cons of investing their time and also to some degree their money in those non-evidence-based approaches. But perhaps the best way at this point might be to identify groups around the country that are investigating this, and there are a number of groups that are, and see if it's possible to participate in a clinical trial. One of the good things about cognitive training is you don't necessarily have to go to the office. You can do it on a laptop, or you can, these days, many of the projects that are underway trying to validate this approach are using web-based technology. So you don't necessarily have to live in the town where people are doing the study.
Excellent guidance. And just to, would you be comfortable saying that really as a general rule of thumb, for somebody who does have a diagnosis of schizophrenia, they should be speaking with their psychiatrist about some type of cognitive training or rehab as a part of their overall treatment plan?
Yes, I think that's very important. And sometimes that starts with the psychiatrist fine-tuning the medications to be sure that there aren't medications that are contributing to sleepiness or forgetfulness and making cognition even worse than it needs to be. And I do believe that at this point in history, all practicing psychiatrists who work with people with schizophrenia diagnosis are well aware of the importance of these deficits. And by talking about it with their doctor is a very good first start.
Good, excellent. And in terms of the neurostimulation, that is also the type of thing that somebody can do if they're in a trial. That's not something that's being used in regular clinical practice.
Yes, absolutely. This does not rise to the level of an evidence-based practice. I think probably we're close, getting close to the point where we could say that cognitive training, and as I mentioned, there's a number of different approaches, represent an evidence-based practice. But I think with transcranial direct current stimulation, that is very new, and it's definitely not an evidence-based practice. So that definitely needs to be undertaken in an investigational setting.
And in that setting, have there been any negative side effects from that approach?
Yeah, so there have been a lot of studies in sort of healthy young undergraduates, and also in people post-stroke, where actually this has become something of an evidence-based practice. And there's a growing number of studies in psychiatric patients. And the really good thing about this approach is that there really aren't adverse results. There's sometimes some tingling or itchiness or a burning feeling in the skin where a person's being stimulated, but that's about as far as it goes.
Okay. So it really is a safe approach, and once there's more evidence to prove its efficacy, it might be something that would be much more widely used in clinical practice.
Absolutely. I think that right now we don't know enough about exactly how to do the stimulation, what the parameters are, which kinds of training or tasks to combine the stimulation with, how often to do it. There's a tremendous amount that we don't know. So I present these data, which are as yet unpublished, will be presented at a scientific conference later in the year, really just to show people how we can actually take advantage of what we have learned from using these cognitive neuroscience tools, and start to use that information to move towards developing treatments. It's not really something that I'm advocating for, although it is something that I think could hold some potential, And it could help people who might not everyone benefits from cognitive training. And part of the problem might be that the cognitive training might be too hard for some people. So this might be a way for people who are having a difficult time to engage and benefit from cognitive training. And it might be a way to increase the benefits from cognitive training altogether. But we're at a very early stage now.
Right. But with real potential benefits for people in the not-too-distant future, and as you pointed out, often these symptoms are as troublesome, if not more troublesome, than some of the positive symptoms that are more remediable with medication.
Yes.
Yeah. I also want to ask you about the use of biomarkers. And the studies that you presented are studies of groups of people that show differences between people who have a diagnosis of schizophrenia and people who do not, and it provides very important information. But how far are we from being able to, for an individual person, be able to use these techniques to help make a diagnosis and help monitor how well the treatment is going?
We're a little ways away from being able to do that still. We know that with most things that we can measure in patients that will distinguish patients from controls at the group level, there's a fair bit of overlap at the individual subject level. So that's a challenge. I don't think there's any measure that's come up where just by itself it provides the kind of specificity, it's what we call the positive and negative predictive value that we would consider a biomarker in the same way that we would say, blood glucose level or fasting glucose level for diabetes. So that overlap between control subjects and healthy subjects makes that very difficult. There are some computational image analysis methods where either statistically or using a computer model, you train the model to recognize patients and controls based on one or more pieces of information from brain imaging. And there are some promising results that suggest that we could be getting closer to using these things that we can measure already in that way, but we still aren't there. Those methods haven't been refined to the degree where you can obtain the kind of positive and negative predictive values. So we're not there yet for sure, and we've probably got a little ways to go. I did my psychiatry residency training in the 1980s, and at that time we knew every idea that we had about what was going on in the brain of a person with schizophrenia or bipolar disorder came from animal research and kind of extrapolation. And so we've come an incredibly long way in 20 years. There's a long list of things that we know now about the brains that we can measure in individual subjects. And so we can use that to help us to develop better treatments, and we can continue to develop the methods so that we can strive to be able to use these tools for diagnosis. And from that point of view, it's incredibly exciting. But we're not quite there yet with regard to using brain imaging for diagnosis.
Right. We're not ready. It's not yet ready to help individuals in making a diagnosis, but it certainly is very much a tool in helping research determine a better understanding of the brain, of what can go wrong in people who have certain illnesses, and then lead us to potential actions to make things better.
Yes, and compared to where we were 10 years ago, we are a lot closer to using this diagnostically. We're just kind of not at the point where anybody would claim that we've actually arrived.
Right. Another question that came up related to cognitive training is the use of that technique in people who have a diagnosis of bipolar disorder.
Right.
And I'd like to ask you to say a few words about that.
Sure. Well, there's very little data about that. But I can tell you with this growing focus over the past several years in the similarities as well as the differences between bipolar disorder and schizophrenia, we have begun to look at particularly the cognitive deficits that we've seen in our schizophrenia patients, in our bipolar patients. And these are people who are coming to us after having had some psychosis. So they've typically had a serious manic episode with some psychosis. And those individuals have surprising levels of cognitive dysfunction. So we've also been following over time, and there's definitely at least a subgroup of them for whom those cognitive deficits don't get better when their mood symptoms get better. So I believe that it's probably time to think about identifying that group of patients with persistent cognitive deficits and also attempting to do cognitive remediation and cognitive training with those individuals as well in order to get them to be able to function better.
Our time is running out, so I want to just say, Cam, this has been an outstanding presentation. A number of the questions weren't actually questions, but just comments saying what a fantastic presentation this is. And I want to thank you for taking time out of your busy schedule to share this information with us, and also thank you for your ongoing research, which is really having an impact on the field and will help people really make a difference in their lives. So thank you so very, very much.
You're welcome, Jeff. I am very honored to be able to give this presentation for BBRF. Without BBRF, many of the researchers that are involved in the field right now probably wouldn't be here. So thank you very much.
Well, thank you. And I also want to thank our audience for joining us today. The foundation, through its research grants, is dedicated to improving the lives of people with a wide variety of psychiatric conditions. And I want to thank you for joining us on that mission. All of the research we fund is made possible through private donations. And I'm going to ask people to please make a gift. Visit our website at bbrfoundation.org or call our 800 number, 800-829-8289. As Dr. Carter said, the funding through the generosity of our donors has had a tremendous impact on the field and on developing especially young scientists to developing their interest and their ability to do research on the brain. This webinar has been recorded. If you've missed any portion of it or would like to share it with a family or friend, visit the webinar page on our website. I hope you'll join us again next month when we'll hear about a different topic from Dr. Dolores Malaspina, Professor of Psychiatry at New York University School of Medicine and the Director of the Institute for Social and Psychiatric Initiatives. Dr. Malaspina will speak to us about, quote, identifying risk factors and protective pathways for schizophrenia, unquote. And this will take place on Tuesday, July 15th at 2 p.m. Eastern Time. Thank you again, and enjoy the rest of your day. Take care. Bye.